Dr. Kavros?
Thank you very much. As Beth just mentioned, this first segment will just give you an idea of what this technology has, how it separates from other technologies, and what the great value is in the complex area of the wound healing cascade. And that's really integral, because if you take away, all of us take away a couple points at the end of a talk, and if you remember anything, hopefully you'll remember how this product really integrates into our normal healing on an acute side to take a chronic wound that is really undulating and cyclical and doesn't heal, and put it into a trajectory for the acute healing cycle, so you have a linear pathway to closure. So the electrospun nanotechnology isn't brand new. It has already been accepted in many other domains, both medical and non-medical. And as Frank just alluded to, it's been very successful in the vascular. As Mr. Ronnie Bracken alluded to, it's getting some great evidence-based healing in rotator cuff repair in the shoulder. And as a past pitcher, hopefully they'll implant it in me in the future. In the neural tissues, it's shown great success. And again, musculoskeletal, I believe it's going to be a game changer for a lot of the soft tissue injuries that us weekend warriors that once were really good at what we were doing, now we just hope that we can survive. So whether it's an Achilles tendon tear down the road, it's a rotator cuff, it's a bicep injury, it's a hamstring injury, there's going to be utility here. Thank you. Next slide, please. So what is the nanofiber? Again, it's a bioengineered scaffold that truly mimics our extracellular membrane. And if anybody has been involved in this regenerative world in the past 20, 25 years, it's all about the extracellular membrane. That's what it all comes down to, and how it integrates into our system. Too many people out there in the clinical world view allografts, xenografts, and even some live tissue cells as something that really stays with them. And especially in the xenograft world, it doesn't. It degrades, it breaks down, and eventually your own collagen takes over. Well, this nanofiber technology has the integrated ability to mimic our own extracellular membranes, and has the size, the particle size, the affinity for particulate attachments to the key cells that make it sustain and let you go on and heal. So at the end of the day, it produces and promotes the normal linear healing of our wound healing cascade. Next slide, please. So what's all this about the alignment of fibers? Collagen, as we all know, is the #1 protein in our body. There's nothing that exceeds the number of proteins in our body besides collagen. Each collagen is independent and they're unique. So a cardiac collagen, a small smooth muscle of the intestine, a skeletal muscle, they all have different collagen alignments. And this technology can produce different alignments for what you want to do. And that's really important when you're trying to mimic a specific cell or organ type. Next slide, please. So if you look at a collagen structure or a scaffold structure, if it's aligned in neural tissue, if it's not aligned, I should say, in neural tissue, the cell will attach, but that cell doesn't have the normal architecture. If you make that scaffold aligned correctly to what that normal neural tissue really is in living tissue, the cell is going to align in a linear fashion. It'll survive and it'll attach 5 times greater than in a haphazard way. So the alignment that is produced by this nanofiber technology and manufacturing is very, very important in tissue engineering. Next slide, please. And again, this just shows in an immunofluorescence the alignment and the linear alignment of cells that are attached. And 3D is really, really very, very important, because a lot of these xenografts, for example, they claim that they're 3D, but when you look at them under a scanning electron microscopy, they're really more on the 2D side, because those cells that attach with micromotion don't stay adhered and they go away. And if you have a true 3D construct, these cells are not only going to attach, but they are going to continue the lattice formation and have viability to that structure. And that's imperative in successfully getting a fibroblast to attach to the scaffold and let that fibroblast go on and mature and produce the collagen that we need for the ECM. Next slide, please. So, okay, so the bioengineered electrospun synthetic technology, again, just to reiterate, is a temporary microenvironment to support our normal endogenous wound healing from the insult of the wound to the inflammatory phase, through the proliferative phase, and going through the maturation phase. It does contain no human cells, so there's no immunogenicity to something that might not be your phenotype. It has no animal tissue or cells, and therefore, when you produce a xenograft, you have to take a pig, a cow, a goat, a horse, and basically put detergents through that tissue to make it clean and remove the cells. But even though they say they're 99.8% cell-free, there still could be some immunogenicity. There is nothing with this bioengineered tissue of electrospun. And it is rather a selective polymer and composition, which can really give you the flexibility to go through those phases of wound healing in a natural process. And that's very, very important. Next slide, please. So now with Phoenix specifically, there is a way to produce this nanofiber technology through current, through pressure coming out, to extrude the material and make it appear very, very similar to human collagen scaffold. And that's really important, because again, you've got a 3D structure that our cells will identify as normal, attached there, and do what they have to do. So a fibroblast is going to produce collagen, a platelet's going to attach there, and it's going to produce all its growth factors. And those normal functions accelerate and again, take the wound with other factors that this will do, which I'll talk about shortly. It'll take that wound from a chronic phase that's undulating and haphazardly trying to figure out what's going on to a nice linear phase, so it ends up going to closure. So these particles are quite small, as the previous slide just showed. The value that is really getting a lot of discussion today, which is kind of new, but anybody who's been doing this for long enough, you know, things go in cycles, and basically they're 30-year cycles. 30 years ago, we were looking at pH in the wound bed, and it kind of dropped off. It's coming back again now. And at the Wound Healing Society that I just participated in here at this meeting, there was a lot of talk about pH in the wound bed. Well, Phoenix Wound Matrix has already addressed this and addressed it extremely well. Acute wounds basically do not have a problem with pH. They're not bioburdened. They don't stall. Chronic wounds do. And the really important thing in a chronic wound is the pH of a chronic wound is alkaline. They're 8 to 9 on the pH scale. Nothing heals in an 8 to 9. So if you're using any products, and you might want to ask some of your nurses and your other docs and your providers, what's the pH of your dressing? What's the pH of your solution? If they're saying, and honestly saying, they're alkaline, I'd kind of take a step back and think, well, maybe there's something better that I can put in the wound bed, not just for the tissue integration, but for the entire healing process, because it all goes together. So the pH value that Phoenix offers is it brings the pH down to the normal pH of skin and dermis. And that's extremely important, again, and I keep repeating myself because it's so important, that it brings it from a chronic stage to an acute stage, and that's how you heal. The next slide, please. So what is Phoenix made of? What is this nanotechnology made of? Well, it's 3 different acids: glycolic acid, lactic acid, and caproic acid. And if any of you in the audience, and I'm sure that everybody out there has had a surgical absorbable suture in their hand at one time, those are absorbable, and they're a combination of 1 or 2 of these acids. So, inadvertently, we've been using some of this stuff for decades already. And some of those non-absorbables do release these acids, which bring the tissue down to a little bit of a acidic environment again, or a normal environment for the wound healing. And why is that so important? For so many reasons. It helps mitigate and control the bioburden. Anybody who's taking care of wounds knows that the biggest offender right off the bat in the first couple hours of an insult is infection. That's why we have white blood cells that reduce hyperchloric acid to engulf them and kill them. You got to get rid of the biofilm. If you have biofilm and bioburden in the wound, nothing grows. The higher the acidity in the wound, the greater the bioburden. You got to get rid of that. And that's why one of the major effects of the degradation of Phoenix wound matrix is to keep it acidic and mitigate the bioburden. The other very important factor is it regulates the post-inflammatory factors. Matrix metalloproteases, tissue necrosis factor alpha, interleukins. Everybody hears these words and they think, oh, God, they're horrible. They're not horrible. Too much of them is horrible, just like anything else. Too much salt could give you hypertension. Too much cholesterol could give you plaque. Too much MMP 6 and 9 can stall your wound. Too much IL-8 and 1 can stall your wound, and so on and so forth. The degradants of Phoenix matrix help mitigate the amount of these post-inflammatory factors in the wound. And what does that do again? It puts everything in balance, get rid of bacteria, promote angiogenesis. And when you promote angiogenesis and you have more blood cells, you have more nitric oxide, it just keeps promoting good, healthy tissue. And most importantly, again, don't forget about the #1 protein in the body, collagen. It has to produce collagen, and healthy collagen, not senescent cells, not cells that are apoptotic, healthy collagen cells, fibroblast cells that produce collagen to continue in this weekly or in this normal environment of the dermis. Next slide, please. So again, this pH modulation is extremely important. And again, the degradation of these 3 acids maintain the wound bed into a homeostatic environment of normal dermis. Now, you might say, hey, you know what? The blood is 7.2 pH. You're telling me you want to bring it down to 5.5 to 6 for the dermis. Well, exactly. That's what I'm telling you. We are not promoting that this material floats off and circulates in your blood and is acidic in your normal pH of 7.2, but in the wound bed, that's where it's important. It's important where those cells come, not floating through your blood, but into the wound bed. And that's the essence of naturally keeping it in the dermal range. Next slide, please. Again, as I alluded to, it does support angiogenesis, which is essential in building granulation tissue, which lays down more collagen, which brings in blood flow, which is important to get oxygen to the wound and take the respiratory products of the cells away from the wound. Without angiogenesis, we have nothing. If you don't have blood, it's the old thing, you can't grow grass on concrete. So how do you get the good cells there? By keeping a good homeostatic environment. Next slide, please. So again, as I alluded to in the very, very beginning of my spiel here, the Phoenix wound matrix is beneficial in all 3 of these wound healing phases: the inflammatory phase, the proliferative phase, and the remodeling phase. So if you have a product that can absolutely help phase 1, 2, and 3, I think you've got pretty much of a winner. And that's why, again, what I've seen in the number of cases that I've done, it has taken a wound from a chronic stage and put it into that acute phase to go on and heal. That is, it's more than novel. Again, I've had the pleasure of taking care of thousands and thousands of patients with all these different products, starting in probably 1997 with Bilayer from Integra. The first xenograft that came out was the subcutaneous intestinal Oasis. It was revolutionary at that time, a lot of science behind that time. We have progressed to over 107 living cells, xenografts, allografts. How do you pick? Well, I think you have to learn how to pick by what works best in your hands, what works best in the environment that you're trying to do, and what's the best outcome that I can deliver to my patient. And if you have a product that can integrate to every single phase of the wound healing cycle and be productive and significantly impact it, I think that takes some serious consideration. Next slide, please. Beth has compiled this wonderful chart here. And again, due to my lack of time here, I'll just go through a couple highlights. This is a large case series that Renovaderm is just ready to publish. They've done 47 patients with 65 wounds. And if you look at the very top bar there, 100% 88.2, instead of going through each one that you can read at your convenience, they have demonstrated a tremendous amount of efficacy in this product. The median wound area reduction in 4 weeks over these 47 wounds is 88%. The average application was only 2. The median time for closure is 5 weeks, which is very, very aggressive. But most important, some of the very important things that you can pull from this slide too is, as we move down, as CMS and our payers and our governments look at how they spend money, I think the products that you're putting on 8, 10, 12 times with a high cost is going to be highly scrutinized, as opposed to getting the same outcomes with 1 or 2 applications. I think that's a really key point right now to consider, especially when you're doing physically responsible things for your wound care centers and your hospitals for survivorship. Next slide, please. And just in closing, 2 really quick little cases. This, we all have our non-compliant patients. This guy was right at the top of the board, but a large DFU post-surgical from amputations and so on. In the first application, there was, between the time of seeing the patient, the first application, there was only a 0.8% reduction in the wound surface in 3 weeks' time, with 1 application, and only 1 application. In the second evaluation, he had a 32%. And this was with a gentleman who would not offload. He would not change the bandage once a day. So if I got this gentleman to reduce in 32% of the wound size in 3 weeks with basically doing nothing to support what I'm trying to do, I think that's a pretty good win right there. Next slide, please. This individual was really primary lymphedema, but she had a secondary, a wound secondary to her lymphedema and her venous insufficiency. Her GVS was just horrible. And she was not a surgical candidate, even an interventional candidate. She was a high risk because of other cardiac conditions. However, again, from the first application, the first time of seeing her to the first application, she had an 8% reduction just with compression therapy. With 1 application of the Phoenix Wound Matrix, she had a 37% reduction in 3 weeks. Her pain was probably 1/3 of what it was initially. And one factor that I really haven't even discussed with Beth or any of the other colleagues here is, again, I'm kind of blessed with doing a lot of research. One of the things that I have at my fingertips right now is a pH meter that can actually test the pH of the wound, not a litmus paper, but an actual probe, 2 probes that go into the wound. And what I did was, with the the first day on 10/26, I took, after debridement tissue, put it in saline and did a pH. Her pH was 8.9. After the last day of the picture here, a few weeks later, 3 weeks after the application of only one Phoenix wound matrix, her debridement tissue and exudate, and all these tissues have, I mean, all these wounds are quite exudative, obviously. Her pH of the wound slough and her exudate was 5.8. So she had what I just reviewed was a significant reduction in her wound bed to a almost normal or really a normal pH of dermis. And to me, it's an N of 1, but that just validates clinically what I see. What I see. So anyway, that is my